Thank you, everyone, for attending. And this is going to be the first of a multi-part series on the use of fluorescence imaging in cancer surgery. And I am your moderator. I'm Thinzar Lwin. I am a surgical oncologist at the City of Hope in California. It's in Southern California. And today I'm joined by three incredible panelists that I am very excited to introduce. We're going to be speaking with Dr. John Lee from Penn, who is a neurosurgeon who has used the fluorescence in the resections of gliomas. And I'm excited to have you share his images and kind of hear about what he's been able to do in that field. And then the second speaker that we'd like to introduce is Dr. Sunil Singhal, who is a thoracic surgeon also at Penn, and he's really pioneered applications of the indesigning fluorescence for thoracic surgery. And then in a third application of fluorescence and fluorescence guided surgery, I'm excited to introduce Dr. Kenneth Rankin from Newcastle on Tyne in the UK. And we appreciate him joining us because it's so late over there. But he is applying ICG for the resection of extremity sarcomas, and he's an orthopedic surgeon there. So these are the different applications of indocyanine green and fluorescence for sarcomas. For this session, we're going to focus on indocyanine green, but I'll start with a quick overview of the objectives that we hope we can achieve during this time. We'd like to further the technical understanding of how ICG technology and really fluorescence technology broadly can be applied to oncologic surgery. We know that there are a lot of different doses, time, and in the world of benign disease, but in the cancer world and using it for labeling cancer, there are also nuances in the doses and timing. And so we want to also understand how this can be potentially used for improving oncologic outcome. There's now emerging data on how fluorescence can be used to improve surgical precision and outcomes in identifying, excising, and reducing the rates of local recurrence. So we want to kind of hear some of our speakers touch on these topics. And really, throughout their presentations, we'll get an idea of the critical evaluation of the clinical data that's coming in. What are the experts using to evaluate these emerging technologies? What are the benefits and limitations? And how can we, as surgeons using fluorescence, evaluate similar technology as they further develop? And what are the common barriers for institutions to really adopt this in the clinical practice? Implementation challenges and the cost effectiveness of it. It all goes together in trying to get institutional buy-in for this type of technology. And as a last point, I'd like to inspire innovation and identify future directions in research based on what is going on. Because really it is only through collaborative approaches that we can really advance the field. So I'm going to give kind of a brief overview of oncologic surgery and how fluorescence applies to this. The goals of oncologic surgery are identify cancer, identify any metastasis, if any, whether the histology of the cancer is lymphatic spread, local spread, or distant spread, identify what's normal, identify what's the cancer, remove what's the cancer, and limit resection of normal tissue. But tissue identification in oncologic surgery is very difficult because the minute the tissue leaves the surgeon's control, then the three-dimensional spatial relationship as it transfers to the pathologist can be very difficult. There are different approaches in inking and orienting and stitches and clips, but really there's a rich network of information that is lost the minute the tissue leaves the body. And we'd like to be able to continue that information and be able to really understand the tumor and the surrounding tissue in situ and in real time, rather than relying on fluorescence, which necessarily destroys the tissue by needing to freeze, slice, and stain. So fluorescence, we believe, can be used to apply to cancer surgery, and we can use this technology. We are giving an agent to the patient. It collects at the tumor preferentially, and the camera excites that fluorophore and collects that signal. And the potential uses are in surgical oncology are, as I mentioned, detect the tumor, the margin, detect metastatic disease, and another benefit is it could potentially help pathologists better identify the areas which should be looked at under histologic microscopic evaluation. And another area that we will touch on in the future are identification of normal structures like nerves, ureters, blood vessels, etc., to help augment what is being resected. So the field of fluorescence-guided surgery really has expanded in the last 10 or 15 years in both benign and malignant diseases. There are a large array of imaging devices now with fluorescent capabilities that are available for use in our operating rooms, whether it be robotic, open, laparoscopic, handheld, endoscopic. There are a lot of different platforms. So the number of research articles in this field has likewise increased over the past years. In thinking about fluorescent agents and cancer, there are three broad categories. There are the non-targeted fluorescent contrast agents, which we'll be focusing on today. There are targeted fluorescent agents. There's homing probe or beacon, which brings the fluorophore to the tumor by way of tumor-specific overexpression or tumor metabolism of certain agents. And then there are activatable agents that are quenched upon infusion, but due to the tumor microenvironment, unshield the fluorophore. So those will be addressed in future topics. And today we're really going to be focusing on the non-targeted fluorescent agents and how these can be applied to cancer. And indocyanine green is the most widely used agent, and it's safe. It has a long history, and it's very well tolerated in patients. And you'll see through the presentations of the other presenters how different doses can be titrated for highlighting tumors. Indocyanine green has a very interesting history that I wanted to highlight here. It's actually developed in the 1950s via Kodak for pictures, but was then used for liver function tests and cardiac function tests, because the blood metabolism of indocyanine green is processed in a very linear way. So this is a very interesting component of indocyanine's rich history. Now, though, the common application of fluorescence and indocyanine green is in perfusion. We give the agent, it rapidly distributes, and this is used in bowel perfusion, flap perfusion, and fluorescence angiography. And it can also be, because of its metabolism by the hepatobiliary tract, it can also be used to later on delineate the hepatobiliary anatomy. But fluorescence and ICG can also be applied to highlight tumors, because there's an enhanced permeability and retention of tumors, whereby the tumors have abnormal vasculature and it hangs on to the indocyanine green. So we're excited to see what the other speakers have for us as far as their tips and tricks, how they do it, how they apply it, and what they've seen as far as results in fluorescence-guided surgery and the use of ICG in oncologic surgeries. So without further ado, I'd like to ask Dr. John Lee to share his slide.
Thank you, Helmi, for inviting me to speak about ICG. I noticed that Dr. Kim Hyung-gu is online from Korea, and he's a really amazing thoracic surgeon who has done great work with some very interesting dyes. And so I know that we have some very experienced surgeons and intraoperative molecular imaging experts in the audience. So with that, let me continue. So I have to just start by saying that I credit Dr. Singhal, our next speaker, for all of the work that I'm doing, because it's really his work that I just continued and applied it into the brain. So it's all just derivative of his insight. So in any case, no need to do introductions. I thought this was an interesting thing. When I first started with ICG, the Brian Pogue's paper came out comparing all the different camera sensitivities. And obviously, ICG is very commonly used. So I just wanted to test our microscope to one of the cameras. And it was dramatic how pathetic the existing microscopes are for neurosurgery. So when my colleagues read my papers and they tried it, um, tried delivering ICG and then visualizing tumor, they couldn't see anything. Well, it made sense because our camera systems, you need to get the right camera. So you need the best visualization system possible. And so using Brian Pogue's paper, we chose a particular camera that had the highest dynamic range, the greatest sensitivity. And unfortunately, that camera is really not being sold for this purpose anymore. But it was very useful to go through this exercise and just to understand. Because, so for example, here's a good view. We have white light and then the tumor in white light. Then look in near infrared. So you compare, this is the existing microscopes from here to down here. And then you compare that to the better systems, the systems that are tuned for high sensitivity. And it's really dramatic difference. So my colleagues couldn't see the tumor with our technique. So we're relying essentially what we believe is EPR. Now, what I tell my colleagues is, when we give gadolinium for our MRI, which is our gold standard for diagnosis, we expect it to leak into the tumor, and then it provides that magnetic contrast. And that's how we visualize the tumor and localize. And then we do our stereotactic navigation. We put them in rigid head pin fixation. We then use the three-dimensional tracking and find the ICG. We find the gadolinium. And wherever there's a bright white on gadolinium, that's what we want to resect. Very similar. The ICG leaks into the tumor. It sticks around. And gadolinium probably washes out within half hour. So if you keep imaging it, there are interesting studies where you keep imaging it and you can find residual, and you can watch its washout and clearance. But so in any case, once when I explain that to my colleagues, it makes sense. So these are just all examples of tumors. So for example, this is a glioblastoma, and here in the parieto occipital region, and there's a thin rim of normal cortex. And when we look with our normal eyes, that's all we see, normal brain. But of course, because ICG is near infrared and we can excite the fluorophore and then see through approximately a centimeter of tissue, we can get that diffusion of light and visualize it. So we did some preliminary work. This is an interesting slide because many of my colleagues are familiar with 5-ALA. 5-ALA has been around a long time. It's a pro-drug that orally administered. And I'm going to compare our sensitivity and specificity results to 5-ALA. But what was interesting in this study, which we knew, is that 5-ALA requires enzymatic conversion, so the tissue has to be alive. So the center of our tumors, which can be very necrotic, don't convert that dye, and there's no red fluorescence. But interestingly, we get plenty of ICG accumulating in the middle of this tumor. And so I think that can be a benefit, actually, because we need to remove all that necrosis also. My cameras that I've used has two versions, the exoscope and an endoscope version. Now, this is painful because when I do the surgery, I'm using a microscope. I'm using a $800,000 sophisticated counterbalanced system with incredible optics. And then I got to move that thing out and then bring a very sensitive ICG module visualizing agent, but it's only in 2D. It's actually it's actually kind of cumbersome to bring one instrument in, one camera in, one camera out. So, and it's also two-dimensional, so it's not ideal, but we make it work. But that does raise barriers for adoption. I've been talking about this technique for a decade now, and I don't think anybody's adopted it. I have one colleague in Japan. I think there are some ways to address that because I think other challenges, our operating rooms sometimes have windows. We have to shut off all the windows. Another big problem is that all of our localization systems shoot near infrared, bathe the field with near infrared. And so if you just take your near infrared camera and just look up at the cameras, I mean, everything's blinking. So the whole field is blinking all the time. And so I have to push my navigation systems that way. Um, so I bought a navigation system that shoots the near infrared away from the field. And that I was very happy with that system. They just showed me their new product. They're so excited about it. They said that it's a hybrid. It can do both. So now they're bathing my field with near infrared, and it can shoot from the other direction because it has a passive camera. And it's just basically they ruined the advantage that they had from. So this using near infrared can be a challenge in our world. I'm going to skip the video for sense of time. So this is we've done over 370 cases. We did 2 different doses. We did 5 mg per kilo and 2.5 mg per kilo. I just wanted to bring the dose down. And what was interesting is at 2.5 mg per kilo, we never had, actually at 5 mg per kilo, we had a few patients, especially meningiomas, which are benign tumors, where we couldn't see any dye. And ultimately, we realized that we had so much dye in the tumor, we were quenching. So that's why we backed it down to 2.5 mg per kilo. And so that actually has worked almost as well. And then I'm actually conducting a study now where we're lowering dose even further. So it's been very safe. We mix it, so 70 kilo person will take 14 vials of this dye. We infuse over an hour, and we administer it the day before surgery. So that's been very, very successful. So here's our GBM examples. Oh, so I do my resection under white light, then I look for any residual. So now using that, we had about 80 patients. Our signal background's very good, and we can see through the cortex, we can see through the brain. Here's our sensitivity specificity, 137 total samples. Sensitivity is pretty high, 95%, but our specificity is only in the 50s. PPV is very high, 95. Now, if you remember, 5-ALA was able to get FDA approval just based on PPV alone, the positive predictive value alone. Many neurosurgeons went to the FDA and argued, look, we don't randomly biopsy non-tumorous areas in the brain. So that was very helpful. So for here, I'm comparing the 3 pivotal studies of the PPV of 5-ALA to my technique. We're slightly lower than 5-ALA. So I think we're 95% in their pivotal studies. They have a gradation of strong, weak, or any, and they might be 98%. However, what was interesting is if you, this is a literature review, not just the 3 pivotal studies that they submitted. And if you look at the negative predictive value of 5-ALA, so if you biopsy an area that has no red fluorescence, but if you, the negative predictive value is really low, it's in the 20 percentiles. Whereas at least my technique with second window is 50%, but it's flip of a coin. So is it better? It kind of depends. So that's the literature review of the negative predictive value. I think that this technique, it's certainly cheaper than the 5-ALA. Now, what other uses do we have for the for ICG, second window ICG? One thing I think that's really useful is that it helps predict our gross total resection rate, so our postoperative imaging, because we use the post-op imaging as our definition of GTR. So here's a right temporal GBM, here's the fluorescence that you see on the surface, and then when you resect, There may be some trace tumor there. And again, we don't do en bloc resections. I'm not resecting the entire temporal lobe. Now, there is discussion about that as potentially valid strategy for better oncologic resections. But in general, we are doing we're just resecting the tumor itself. And so identification of normal versus abnormal is very critical. So there's this blush of ICG here, and does that correspond to this blush of gadolinium on the post-op MRI? Here's another example of a tumor that this is the pre-op view, and then the post-op. Here's some residual tumor that was left behind, and you can clearly see residual ICG. And so I've come to rely on this more aggressively for the post-op view. And so this is a paper which looks at the sensitivity, a prediction of MRI, and our sensitivity specificity of predicting the MRI result, GTR. So not only have I tried this in primary tumors, we've tried this in metastases. It's very useful in metastases, except for maybe melanoma, because sometimes with hemorrhagic melanoma, apparently, specifically, we don't really get great results. Sensitivity is 99 and positivity 86. The specificity is pretty low, though, because you can have some ICG that just doesn't. I'm going to skip the video. I think for benign tumors, they're not infiltrative, so it actually works quite beautifully. So I find for benign tumors, even though the specificity can be pretty low, it's quite a valuable technique. We've tried it in pituitaries, many other tumors, and we've published results in those as well. So in summary, using our technique of 2.5 or 5 mg per kilo infused over an hour, 24 hours before the surgery, has been quite successful in providing EPR-like contrast. However, our challenge is certainly specificity, and there hopefully will be new techniques to improve upon that. So I'll just end there and save it for question and answer.
Thank you very much. That was a great overview of all the neurologic tumors that have been tested. Now I'd like to introduce Dr. Sunil Singhal from Penn. He was one of the pioneers in using second window ICG for surgical resection and oncologic applications. And I'd like to see the presentation and his insight into what he's been able to do and how we can foresee advances in fluorescence in oncologic surgery in the next coming years. Take it away, Dr. Singhal.
Oh, yeah. Thank you for the introduction. And John Lee is pretty modest in that this was not all my invention. Actually, we did a large part of this together, especially in the early years as we were working through the process. So I was going to actually speak a little bit more broadly, but we can refocus to talk a little bit for time on lung cancer and the whole idea of intraoperative molecular imaging, or IMI, of lung cancer. Before I start, I want to just make an announcement. I hope people can make our meeting in November. It's going to be the 4th. Every other year we do this clinical trial update. John Lee's the course director. It's going to be in Philadelphia in November. No financial disclosures. We have in lung cancer surgery, we have 5 or 4 major problems. We have positive margins along staple lines. We have trouble finding synchronous lesions, locating really small nodules, and identifying positive lymph nodes. And the reason is because, as everybody knows, we use our hands and eyes and use cold steel to cut out tumors. And the concept behind intraoperative molecular imaging is identifying these lesions, as you said, as you introduced earlier, for using molecular contrast agents and optical contrast agents. So this is the most important slide of the talk. Is right now there are 6 tracers available or being tested, at least, for lung cancer. So I put them into 3 different categories, as you already alluded to. There's the non-specific tracers, which are by passive or EPR. There's the category of targeted tracers, which are to specific receptors on lung cancers. And then the third category are the activatable probes, which by themselves don't fluoresce, but in the local tumor microenvironment, those are fluorescing. And they each have their advantages and disadvantages, but I'll briefly touch on these with a little bit of extra focus on ICG, which is tumor glow. We call tumor glow basically for anything that's high dose ICG. See, that's an example. John Lee actually termed it, coined it, and made that, actually trademarked it. So we'll talk first about tumor glow and what is the whole basis of that. So you already mentioned this, I won't repeat it, about EPR effect, but the ICG is extraordinarily small, and therefore it does leak into capillaries. It's some bradykinin, which keeps it there, and the oncotic pressure in tumors, it gets trapped in into the cancers. And we started looking about this years and years ago. This is in 2010, we published some of the papers on this. And the basic concept was just to give it systemically. People confuse that because in a lot of lung cancer surgery, people are giving ICG just directly into the tumor. So we give this systemically. It's a 5 mg per kg dose. We need a higher dose for lung cancer. But we do get, and we give it the day before. We cannot do the day of, we get too much background. And the main thing that really, if you look back upon what we were doing for lung cancer, was this is what probably took the first 5 years of our research, was just identifying that we need to give a very high dose because we need to let all the background wash out and let the tumor accumulate the tracer. So we in lung cancer, we can't do the standard FDA dose. We've got to go up to 5 mg per kg. And we got to give it the day before so that the background washes away. And then we get really nice and crisp images of this. And this was just discovered by mistake. You know, we were working on something, people in Japan had been working since 1988 on EPR for small nanoparticles. And then we just did an experiment, and the technician did not kill the mice that day because he had to run to a party, believe it or not. And then he came back the next day, and then he imaged the mice, and there was actually, all the background was gone and the tumor was nicely fluorescent. So that was the real thing that kind of changed our entire direction of our lab, that observation. So I'll give you an example. And this is a 39-year-old patient. You can see they have a single lung cancer, a very small lesion. You can see it's only less than 1 centimeter. So I know most people on this are not used to reading CAT scans of the chest, but you can see right there, it's a small little cancer. And so these are very hard for us to find in the operating room, especially with minimally invasive surgery where we can't put our hands in to locate this nodule. So here you can see it's very hard to locate this nodule. But when you turn on the camera, you can see where the nodule is. And that ring forceps is 1 centimeter across. There you can begin to see where the nodule is. And it's really pretty crisp, and the borders are quite intense. So you don't have to open the patient. Usually on these cases, we open the patient to get our fingers in, but because of that location, we can locate it, capture it, and then resect it. And here you can see after I resected how small, that's my thumb. So compared to my thumb, that's how small that cancer is. No reason to open the patient for a nodule that big. And it demonstrates that we have good borders. You can even see the margins of the cancer. So I showed you the CAT scan. On the CAT scan, there were no other cancers. It was just a single isolated lesion. So and this is every patient at our institution gets a 1 millimeter fine cut chest CT within 6 weeks of the surgery. So then after the operation, we then always look around. This patient, you can see the lung looks perfectly pink, is non-smoker, no lesions. We turn on the camera and we found an additional metastases right there. And so this patient had a metastatic lesion to the lung. Again, you switch back and forth, you can't even see it. And again, this would never have been found on CAT scan. It would have been outside the realm of the resection. We located it and were able to remove this additional nodule. We did 2 clinical trials, but I'll give you the basic idea of the second clinical trial. And so we took 30 patients. This is the first clinical trial, I'm sorry. This was 30 patients. And we knew that they had 53 cancers. So the 30 patients had 53 cancers. We did the standard of care operation. We did 10 patients open, 20 patients by minimally invasive surgery. And when we did the thoracotomy on 10 patients, we found 7 additional cancers. There's no imaging here. This is just, we had the patient. We knew we were going in for 53 cancers. We opened we found 7 additional cancers. By that, when we do a minimally invasive, we found 4 additional cancers, which makes sense because we don't feel around. We are just doing minimally invasive surgery. So the standard of care found 64 cancers. When we added imaging, we found 3 additional cancers in the open situation, but we found 21 additional cancers when we did near-infrared imaging. So we found 24 additional cancers. And so we did this trial, we did it twice, we presented it, and there was a lot of criticism for years that people said, well, we know with metastatic disease, patients aren't going to live anyway. So we actually accumulated 10-year data, and we went back and looked at the patients who had been in the study initially. And I didn't actually believe the data myself. I didn't think people were living longer, but even the oncologists were noticing that people were living longer when we were doing tumor glow. And there was a lot of reasons I was skeptical, because if we operate on one side of the chest, they have met somewhere else. They must be on the other side. I'm like, we're not taking those out. And I also said that, how is it possible? Because these people have stage 4 cancer, we can't be moving the dial. But we actually went back and looked at the data, and we actually had improved survival. So people who qualified for pulmonary metastatectomy, which means going in and removing metastatic cancer, we actually had improved survival. So this was really unbelievable at this point. And we went back even further, and we pulled every chart on every patient going back 10 years. And we used historical controls to kind of figure out why these patients who were getting tumor glow were living longer. Well, it turns out that unexpectedly, a couple of things had happened. The first thing we discovered with the patients who were getting tumor glow, the oncologists, usually they were sending us for 1 or 2 lesions. And when we were sending the patient back to them and saying, oh, we actually found 6 lesions or 7 lesions, the oncologists were doing one of 2 things. One, they were actually preemptively treating the patients. They were saying, oh, well, these people must have more cancers, so they were giving them more aggressive regimens. And 2, what was happening is that some of the patients, they didn't necessarily treat, but they put them on a more rigorous surveillance schedule. And so if they got discovered at 3 months instead of 6 months, they would get on chemo earlier, and we were just moving the dial. So essentially the learning lesson for us was that just using simple ICG, tumor glow, 5 milligrams per kilogram day before, we were improving survival by giving the oncologist more information. And that information was then translating to a treatment change, a shift in the treatment paradigm. And so as working, it is pretty interesting that this technology, people criticize it, well, oh, how is it really helping? Show us the beef, where's the outcomes? These are 5-year clinical data. We're now doing a multi-institutional randomized clinical trial throughout the United States through the Alliance Cooperative Group, trying to reproduce some of this data. And actually a clinical trial is opening up in children now for sarcomas based on these findings. I will go very quickly now because I do want to make sure I leave time for the last speaker. And I know we are a little bit behind, but I will tell you very quickly about the other side of the coin, which is these targeted tracers. What these targeted tracers are very simple. They're tracers with a ligand attached to a fluorophore. So folate receptor is highly expressed in lung cancer. So is CEA and EGFR. I'll tell you very quickly about them. The folate is plain old folate, nothing special, with a double sulfide link to a dye, which is just slightly off it's SO456, which is slightly different than ICG. And it is actually right now the only FDA-approved molecular contrast agent. I'm going to skip all the preclinical work, our phase 1, our phase 2, and our phase 3, but I just want to give you some highlights. The molecule gets endocytosed. So the advantage is it gets to accumulate in the tumor. The folate receptor, we were very lucky. It turns out it recycles every 20 minutes. So it actually, over time, accumulates the tracer into the patient. And here you can see when the tracer comes in, it gets absorbed and it gets into the cell and stays trapped in the cell. The other tracer is being developed at Stanford. It's the EGFR targeted receptor. this is an antibody approach. So we used folate. The advantage of the folate, that's a 456, it's very small. So tissue penetration is excellent. It's not that much bigger than ICG. So we were getting good penetration. And this is the EGFR tracer being developed at Stanford. The disadvantage, of course, is the large molecule. It's 150 kilodaltons. It doesn't get good tissue penetration. And it also, because of it, it's $50,000 a gram. And you got to give it 5 days before. So there are some challenges with this dye, but they're doing nice work. And here you can see on the left upper is the tumor, on the upper right is the dye. And that's from Nally Liu at Stanford. And then the other tracer I'll just mention is a CEA tracer. This is just a CEA antibody attached to a fluorophore. Same problem, $50,000 gram, very expensive. You got to give 5 days before. But I'm not so sure that this antibody approach is going to work. You have to probably stick to small molecule. And actually, they did not use a near-infrared tracer. A little bit surprising. So you can see that the depth of penetration is not very good. You have to really cut into it before you can see it. It can work for some things, colon polyps, which they're being used in, but not very good for lung cancer. And this is a benign nodule. Here you can see that it's specific in the sense that this nodule did not express CEA, and there's no expression at all. So just to close, I'll show you this real quick. A little longer videos. Okay. The last things are the activatable probes. There's two types right now, the cathepsin B activatable probe. So cathepsin B is highly expressed in lung cancer. It's a ICG attached to a quencher, and the linker is the substrate for the cathepsin. So when the molecule floats into the cancer, the cathepsin cleaves the linker, the quencher floats away, and then you're left with the fluorophore. And so these activatable probes are called they're very good because they react quickly. They don't require much doses. They have really little background, and they're easy to use, minimal toxicity. So here again, you can see the quencher canceling out the ICG. Here's the substrate, and it floats into the cancer. The quencher goes away, and the tumor starts fluorescing. We're in phase 2B clinical trial at Penn. We've already done our we've done our phase 1, phase 2A, and now we're in our phase 2B. And now we rolled it out into a multi-institutional clinical trial. And then the other one that is available for lung cancer is pH activatable probes. So in highly acidic environments, they activate. This is, unfortunately, we've terminated this trial. We did not have good fluorescence. That's another longer story, but the pH story, we learned a lot about the pH story in human tumors. It's very hard to reproduce this in mice because they're clonal proliferations, but in humans, we learned a lot about the pH of tumors through this study, and it doesn't work as well as we thought. So on that, I'll just conclude by saying, please come to our seminar in November. John Lee is going to be running that course, and we look forward to seeing you all, and I turn it over to Dr. Rankin.
So now I'd like to introduce Dr. Kenneth Rankin. He is at Newcastle on Tyne, and he is an orthopedic oncologist working with indocyanine green, and his group was the first to publish the use of second window ICG in extremity sarcomas.
Okay, yes, apologies. So it's a bit late here in England. Yes, thank you, Helmi, for inviting me. Yeah, it's a pleasure to talk to you about what the work we've been doing, particularly in terms of sarcoma surgery using ICG and obviously fluorescence guided surgery. That's my disclosure slide. So in terms of where we started, as we've already discussed, ICG has been widely used for assessing tissue perfusion, and our colorectal surgeons were using this as part of an NIHR. So that's in England, the NHS research wing in terms of running big clinical trials. They were using ICG to assess tissue perfusion in the bowel, and in the context of colorectal cancer surgery, using it as a dynamic fluorescence assessment in order for the surgeons to mark up areas of healthy perfusion, and therefore when they did their anastomosis, they were able to see that they had healthy tissue and then reduce their anastomotic leak rate. But in terms of looking at tumor margin identification, the concept, as we already heard about, was giving the ICG the day before surgery to see that if we could identify the tumor margin in sarcomas. So as we know, sarcomas are rare. They're about 1% of all cancers. About 2/3 of them are soft tissue sarcomas, and about 1/3 are bone. And of course, as we know, surgery is the mainstay of treatment, and it's all about trying to get decent margins for good oncological outcomes. And so we did quite a lot of work in terms of the background to this, just to show that, for example, we know that a positive margin is not good for the patient. There's an increased risk of local recurrence and a reduced time to that local recurrence. And that positive margin can also correlate with poorer overall survival. And actually, as an orthopedic oncologist, it's not just about the a positive and negative margin, it's even the width of the margin. So in the context of chondrosarcoma in the pelvis, a margin of less than 2 millimeters has been shown to correlate with an increased risk of local recurrence, and that actually correlates with an increased risk of death for the patient. So the basic question, and it's a good 5 years ago now, and inspired by Dr. Singhal's papers, where if you give a decent dose of ICG the day before surgery, can you cause the tumor to fluoresce, and can you detect that, and can it be useful in the operating room? So obviously the ICG, as we know, has been around for many years, but the game changer, again, as we know, are some of the cameras that are more user-friendly for these surgeries. So this was the first case that it worked well, was this chondrosarcoma in the pelvis, giving ICG. We gave 75 milligrams intravenously the day before surgery. And actually, as we were operating, we could see this is obviously quite a brutal operation. We still have to do as a hindquarter amputation for this tumor because it was running down the thigh. But as we were operating, we had a sense that there was some fluorescence coming through the iliacus muscle there. And actually, our pathologist kind of reluctantly allows us to sample the tumors. And so I dissected into the tumor, obviously well away from the patient, and you could see fluorescence there. So it didn't change what we did for that case, but it did convince us that actually, obviously the ICG had, obviously through the EPR effect, as we know now, had accumulated in the tumor. The next case was a few weeks later, and this was a case of a myxofibrosarcoma in an elderly lady who presented quite late. This is the MRI scan, the axial slice with this massive tumor on the dorsum of the wrist and distal forearm. It had ulcerated through. It also had this radial component near the radial artery. And so this is just before we actually fully prepared the limb. You can see it's a nasty tumor. And then on the infrared mode, clearly there's fluorescence on the different modes of the camera. But where it became useful was in the flexor compartment. You can see there annotated with a white arrow with the radial artery running through the wound bed. And then the red arrow, which was quite frankly looking like tumor to the naked eye. But on the infrared mode, this was just far more obvious. And so that convinced me to ligate the artery, take more tissue off the radius. And you can see there, that's a much cleaner wound bed on the infrared mode, and actually got a clear but very close margin on that patient. But she did not have local recurrence and she's over 3 years down the line from that. And so here's the tumor specimen, just to show on the different infrared, another infrared mode, the fluorescence there. So actually just looking at a series, so the obvious thing to do, one of our fellows said, well, we've been doing these cases for about 2 years now. Why don't we look at cases where we've used the ICG and infrared guided, near infrared guided surgery versus cases that haven't had it? And actually, the UPM, there's the unexpected positive margin rate. And actually, it's a lot lower when we've used the ICG, which was a bit of a surprise. But of course, it's a small number of patients. It's not randomized. But it was a bit of a signal that perhaps, well, certainly not worse, and looked better on that series. And that really spurred us on to spend a couple of years building an application to the NIHR to get funding to run a full-on randomized controlled trial in sarcoma, and essentially patients to be randomized to receive fluorescence-guided surgery or not. And we have funding to open 17 centers throughout the UK. We've just opened last month, and we've got 5 patients recruited so far. And we are going to test this question in 500 patients. So what we've done is we've looked at our unexpected positive margin rate in a mixture of bone and soft tissue sarcomas, intermediate to high grade. We know that the unexpected positive margin rate in those patients is 13.8%. And so then if we're going to reduce that to 5%, we need to randomize 500 patients over 2.5 years. And our secondary outcomes are, of course, local recurrence rates, and we have functional outcome measures as well. And that's the flow chart for the trial. We have interesting pathology sub-study and a fluorescence mapping sub-study as well. We are using the Toronto Extremity Salvage Score as a functional outcome measure, and the EQ5D as well. So we're just recognizing that this is going to be an important sarcoma trial with obviously a large number of patients, assuming we can recruit to that target, and therefore it'll be a valuable data set. What's really interesting is we have these sub-studies, so the fluorescence mapping, and there's no time to go into it in a lot of detail, but basically we will, the surgeons will be taking images of the specimens, and those images will go off to a colleague who's a colorectal surgeon in Dublin, Ronan Cahill, who's done a lot of work in this space in terms of applying algorithms to try and assess the fluorescence and quantify it. And then alongside that, we started to look in more detail from the point of view of the histopathology. And so what I've been able to do is start to just pull out blocks of interest from the basic pathology report and say, look, as the example here, here's the close margin, here's some high area of fluorescence, obviously to the naked eye. Let's do some H&E. We've got an interesting sarcoma marker of the immunohistochemistry, and then we can use fluorescence microscopy to look at the ICG at a cellular level. And so, yes, sure, ICG is detectable at the cellular level, and that's led to some preclinical work to try and assess mechanisms of uptake. And of course, that leads on to the development of targeted agents as well. This is just another example of a massive soft tissue sarcoma, which is overlying the femur. So we've taken that out with a section of the femur, so the femoral shaft. But then, of course, as surgeons who are interested in, or sort of amateur pathologists, you start to take pieces of the tumor and bits of muscle and try to compare in terms of what you can do when you put them in paraffin blocks. Can you detect the ICG in a paraffin block? Yes, you can. If you make a 3 micrometer section, you can still detect it. But if you want to see if you can visualize it at a cellular level using the Olympus slide scanner as an example, I think, as we know, a lot of our microscopes in the universities don't really are not really designed to image in the far red zone. But Olympus had quite a nice slide scanner that allowed us to get this sort of imaging where we could zoom right down and see the ICG at a cellular level. So this sort of image took about 6 hours for the technician to produce. And you can see, for example, an osteosarcoma cell with intracellular ICG, but lots of accumulation of ICG in the sort of necrotic hemorrhagic area, just in keeping with what's been described with the EPR effect. And so now we have the H&E, we've got a sarcoma marker, and it's interesting to hear about MMPs. They always come up, but the MT1 MMP is a very useful sarcoma marker on immunohistochemistry. And then we've got the slide scanner. And then if you just zoom in, you can sort of put those images together of areas of interest. And having presented some of this, obviously, collaborating with Helmi, Dr. Lwin got in contact to say that that's some interesting pathology you managed to get out of your specimens. Then, of course, we ended up collaborating with the fluorescence lifetime imaging. We're able to actually, using the same specimens, and this is where you can go quite a long way with the pathology, start to interrogate the tissue in more detail and start to ask questions about how you could image it better, and then hopefully in the operating room at a later date get more effective imaging that you can quantify. So here on the example on the left is the continuous wave imaging, and the high signal tumor cells versus hemorrhage is not so obvious, but on the lifetime, it's clearly that the ICG in the tumor cells has a higher lifetime. And this is the leiomyosarcoma I mentioned earlier with the femoral shaft. And having just simply called for the close margin block from the NHS block and made further slides, we can look at the margin and you can see the fluorescence lifetime works really nicely. This is another case of a proximal tibial osteosarcoma, and the area that I'm worried about this is where the tumor has come out of the bone. You have the soft tissue components. So you may think that bone sarcomas are, you just have to worry about the bone, but actually it's the soft tissue components that come out of the bone that are causing us problems as orthopedic oncologists. And that's where we're going to get issues with local recurrence if we leave tumor behind. And it was quite concerning with this patient that when I'm imaging the specimen at the end, there's definitely fluorescence on that soft tissue component on the medial aspect there. And actually, the patient had neoadjuvant chemotherapy, and the chemotherapy response was disappointing. And in particular, the pathologist was saying that the soft tissue components are viable. So just one case, of course, illustrating it. But the question is, what would you do about this? But the thought process is that perhaps photodynamic therapy could be an option, not just to the wound bed, but perhaps when we're operating, and we could add additional photosensitizers, not just ICG, but the thought process is that we could be treating these tumors while we're operating. So we've done further work. Of course, the easy thing to do is to take some ICG into the lab and do some cellular studies. We've done things such as putting the ICG on a breast cancer cell that grows slowly versus this HT1080 in the literature is known as a fibrosarcoma cell line. It's actually it's a cell line of dedifferentiated chondrosarcoma that's been shown because it carries an IDH mutation, but takes up lots of ICG. And we've done studies just showing that cell lines with a high rate of proliferation take up high amounts of ICG. We've quantified this with flow cytometry here, and also fluorescence microscopy, and then showed if you block pathways of endocytosis, by no means not the only pathway of uptake of ICG, but clathrin-mediated endocytosis is one of the main ones, and caveolin also another mechanism. But if you block these pathways, you can show that actually you can reduce uptake of the ICG. And we're just trying to do further work in terms of modeling in the lab, making tumor spheroids and putting ICG on so you can sort of model the tumor margin and cell invasion. And of course, looking to the future, it's not just about ICG, it's about targeted agents. So we work with radiochemists who can label monoclonal antibodies with infrared dye. MT1MP, as I mentioned before, is a good marker for sarcoma. And that's our radiochemist labeling the monoclonal antibody with infrared dye 800 and zirconium-89, and then doing a CRISPR knockdown of the HT1080 cells. We've got a working model of bone sarcoma, so we place the HT1080 cells into the distal femur, and these will reliably form tumors within. Actually, we can pick up signal on the IVUS in a week, and by 3 weeks there's a big tumor and there's lung metastases by 4 weeks. But using this model, we're injecting the labeled antibody at week 3, and you can see with the mouse dissected out, we've got clear fluorescence from the tumor. And we're also working on Cherenkov imaging, so that's the Cherenkov on the bottom right. And that's really coming from the zirconium, actually. So we're able to utilize that in terms of a sort of dual tracer approach. And that's just the tumor sections, frozen tumor microsections, just to show that the wild type is fluorescing and radioactive. The knockouts, there's reduced signal, and then IgG controls. So we're working with lots of colleagues internationally to try and accelerate some of the preclinical work and just see how we can get some progress into the clinic. And I think it's quite an exciting time in general. Obviously, ICG is very useful, and we have our trial going, but we've got one eye on what we can do in the future. It's just to acknowledge our patients and lots of scientists who've been involved, and fellows and colleagues of mine who are very protective of my time to do research. I don't know if there's much time to show a video just to illustrate ICG uptake, or do we need to finish there?
I think we can roll the video for half a minute, and then I'd love to get into discussions because we're already over time.
Yeah, sure. I mean, this was just really to just illustrate the fact that what happens when you obviously give the ICG the day before, why it's still there, obviously, the next day. So what we did was decided not to give it the day before and set up a patient, obviously with their consent, and give it, ask the anesthesiologist to give it on table in terms of, while we were operating. So we opened up the knee, and the tumor is on the medial femoral condyle. And so that's I don't know if you can appreciate the patella. I think it's more obvious on the videos there. The patella's flipped off to the right side, and the tumor's on your left, and then there's no tumor on the right. And that's our setup. We just clamped the camera up and just had the setup like that, and just ran a video. And basically, I'll just do it as quickly as I can. But basically, as the dye comes in, you can see it actually fluoresces on the lateral side early, which is this side, and then on the medial side, it's a bit slower to fluoresce, and then it obviously becomes very intense. And then the next video is really just showing more of the same. And the next video, yeah, so I'm just moving it on. It took about 20 minutes to do this video, which is what convinced us not to do dynamic fluorescence routinely. But as you can see, this is now about 15 minutes in. You can see the normal side is cleared, really, but the tumor-bearing side is still fluorescing. And it was really just to illustrate the point that that's how it works, right? Because a lot of my colleagues that still asked me, how does that work? Because the half-life of ICG is so short in the circulation. Why is it in the tumor the next day? But it's this point, this is 20 minutes later, and you still got fluorescence on the tumor site. So it was really just to show that point.
Thank you very much for sharing that.
And we did ask our colleagues in just to put a graph on, just to show that the tumor site is lingering. So,
all of the panelists have mentioned ICG, the use of second window ICG, and also targeted probes. How does your experience with ICG and the targeted probes compare? Where does ICG lie? How do you think about it as far as cost effectiveness and applicability as you progress through all the different molecules that are coming into, testing?
I can start with my thoughts. I mean, I think that, first of all, Dr. Rankin, very nice. That was actually really interesting. I hadn't heard that, and I really enjoyed that, actually. And I have a question if we have time, or I can email you later. I'm kind of curious about a couple of things. But, for lung cancer, and then I'm sure Dr. Rankin, Dr. Lee talked about orthopedics and neurosurgery. For certain things like metastatic tectomies, ICG still beats everything. Like, we've tried so many different tracers. We have the 3 targeted tracers and the 2 activatable probes, and ICG still beats everything. I mean, it is so crisp. For things like lung adenocarcinomas, which are highly infiltrative, and that the ICG doesn't necessarily, what happens is that certain cancers, and I think this is why Dr. Rankin's stuff is working so well, they don't always get as infiltrative sometimes, but they compress adjacent tissue, which, as he showed in his picture, they get that sort of pseudocapsule, which then traps the ICG, I think. And we had some data on that. Lung adenocarcinomas do not do that. They infiltrate, so they develop these spiculations, and there we don't get that nice crisp border. And so for those situations, I think any tumor like that, we need a targeted tracer. Another example, for example, is something called thymomas. And thymomas are encapsulated, so ICG works better. And for the carcinoids, ICG works better. There's a number of things which develop these pseudocapsules kind of just by compression, non-invasion. They work really, really well. The problem is that ICG doesn't excite people. The surgeons don't get excited. They think it's just ICG, and a little bit of it is getting people to buy in, to do it. And then the other problem with ICG is there's no company driving it. And there's really very little corporate support, industry support. Whereas when you have targeted tracers, I don't know if you've seen, there's billboards now about Cytolux. There's you could open up magazines in the thoracic surgery community, you can see this. So they're actively, they're actively selling the tracer. So you actually do need the industry to drive this a little bit, but there's no driver. If somebody in the ICG world said, I'm going to drive this because it's using high doses of ICG, yeah, they could do it, but they haven't taken this and run with it in the way Cytolux or on target. So those are my thoughts. But thank you. Thanks for the invite.
Dr. Lee, Dr. Rankin, any thoughts on, comparability of ICG and these molecularly targeted agents? Because molecularly targeted agents, as exciting as they are for all of us who are in the fluorescent world on the scientific aspect, they're expensive. The cost to bring one into the market is tremendous. And then the return on investment for an institution to purchase it. Our institution ran the phase 3 trial for Cytolux, but we're not using it for gynecologic cancers right now. And, that's a question that we're trying to address too. So how do we compare in this, and how should we think about this?
I think every drug needs to be compared to an EPR agent like ICG. I think the reality is that the proof of specificity based on antibody binding or whichever mechanism you choose, I believe is I'm highly skeptical of. I think So that's my perspective, but what do I don't matter. So like Sunil said, if you don't have industry behind us, behind your drug or behind your, it's not moving forward. Yeah.
But you are moving the needle in the neurosurgical space, so we appreciate your input on this. Something to think about also, because we're tackling this from a fluorescent agent perspective, right? Some of the provocative data that Dr. Rankin has provided with the Kumar group, where we're now switching the paradigm. What if it's not the agents that we need? What if it's the camera? What do we need to do to build better cameras? As people who have used fluorescence know, as you get closer and closer, everything glows, right? And Dr. Singhal kind of alluded to, well, encapsulated tumors have a little bit of, more defined margins, but the more infiltrative tumors, it's a haze around there. And as you get closer, you don't get that sharp visualization. And that's a limitation of the way light is bouncing back and forth. And as Dr. Lee mentioned, they're room lights, right? It is rare to have operating rooms with natural light. I have to say, you guys are unique at Penn, but that is, other sources of light can be an issue too. So could there be a paradigm where we combine all of these together to optimize this? And that's something we look forward to seeing in the future. But any other thoughts and comments from those who are able to attend? I know that this is going to be made available on the ISFGF's website, and there's a large audience for this. So we're happy to address any other questions, but we know we are over time. All right, if not, then we'll wrap it up for today. And thank you very much, everyone, for participating. And thank you, everyone who attended.
Thank you, Knight. Nice session. Have a good night.
Thank you.
Good night.
Bye.